Ever feel like your kidneys are these mysterious organs? Hardworking, but kind of mysterious. You know, quietly filtering your blood, keeping everything in check.
Mm.
Well, today we're diving deep into the world of nephrology, all thanks to the incredible material from London Heartbeat's Z Academy.
It's fascinating stuff.
It really is.
Yeah.
Like, they gave us this detailed user manual for our kidneys. And speaking of manuals, hit that subscribe button. Follow us on Facebook, Instagram, Spotify, and YouTube
Yeah, don't miss out.
for more deep dives like this one so you won't miss future episodes. All right, let's unravel these kidney mysteries with our expert.
Ready when you are.
Great. So the document starts by focusing on the nephron, described as the kidney's microscopic filtering factory.
Mm.
Can you break down that analogy for us? What makes this tiny structure so important?
Sure. Imagine like a coffee filter, but much more sophisticated. It's not just grounds and water, it filters your entire blood supply. Carefully separating waste, but keeping the essential stuff, that's the nephron, in a nutshell. Each kidney has millions of these tiny filters, working nonstop to keep your, internal environment balanced.
Millions. Wow. But how do they actually, work? What's going on inside that microscopic filter system?
Well, it all starts with the glomerulus, a network of tiny blood vessels. Inside something called Bowman's capsule. Think of it like a sieve, letting water and small molecules through, but holding back larger proteins and cells. This filtrate, that's what it's called, then goes on a journey. Through a complex tubular system, the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and finally the collecting duct. Each section has a specific job, reabsorbing good stuff back into the blood while secreting waste into the urine.
Like a tiny sorting facility with specialized workers handling different materials. What decides if something gets reabsorbed or secreted?
Now that's where it gets even more interesting. The nephron's selectivity, it's based on a whole interplay of factors. Size, charge, concentration gradient, and these special transporter proteins within the tubular cells. Amazing biological engineering.
Mind-blowing. And this is happening in all those millions of nephrons.
Precisely. This dance of filtration, reabsorption, and secretion, it's happening constantly, making sure your blood is clean, electrolytes balanced, blood pressure in check.
It's amazing how tiny processes have such a huge impact on our health. And speaking of which, don't forget to follow us on social media
Right, keep up with us.
for more deep dives into topics like this. Now, let's talk about how blood actually reaches these nephrons. The document calls this renal hemodynamics. What does that even mean, and why is it so important?
Well, think of your circulatory system as a complex network, like highways and byways, kidneys are a major hub. Renal hemodynamics is all about the forces that drive blood flow into, through, and out of the kidneys, like a traffic system, making sure they get a constant supply of blood to filter.
So how much blood are we talking about here? Is it, a lot?
Oh yeah, a significant amount. Kidneys receive around 20-25% of the heart's total output. That's about 1.2 liters per minute.
Wow, that's a lot. So what if that blood flow changes, like during exercise or if you're dehydrated? How do the kidneys adapt to still filter effectively?
That's where it gets really cool. The body has this system to keep the glomerular filtration rate stable, even with fluctuations. We call it GFR for short.
GFR, okay.
And a key player in this is the hormone angiotensin II.
Angiotensin II. I've heard of that. What does it do exactly in terms of GFR?
Angiotensin II, think of it like a master regulator. It's constantly watching your blood pressure and adjusting the blood vessels going to and from the glomerulus.
Ah, I see.
So when blood pressure drops, angiotensin II makes the efferent arteriole, that's the vessel exiting the glomerulus, constrict. Creates a back pressure to maintain filtration, even with less blood flow.
Like a pressure valve, making sure the filtering stays efficient no matter what. So we've talked about filtration, but this document also mentions reabsorption and secretion. So it's not just dumping everything out, right? The kidneys are choosing what to keep.
Exactly. Along the nephron, substances are either reabsorbed back into the blood or secreted from the blood into the filtrate, depending on the body's needs. Sodium, potassium, glucose, amino acids, all carefully regulated to keep that electrolyte balance we talked about.
Wow, it's fascinating how they can, tell the difference between all these molecules, knowing what to keep and what to get rid of.
Indeed. And this highlights how important diet and hydration are for kidney health. Too much sodium or sugar, for example, it puts extra stress on them to keep that balance.
Makes sense. Healthy choices help the kidneys do their job. Okay, before we go further, reminder to follow us on social media.
Yeah, stay tuned.
Facebook, Instagram, Spotify, YouTube. You'll get updates and never miss a new deep dive. Now, I'm curious about how doctors assess kidney function. I know creatinine is important here, but what is it exactly, and how does it relate to kidney health?
Well, creatinine, it's a waste product from muscle metabolism,
Mm.
filtered out by the kidneys. So its levels in the blood can give us a peek into how well they're working.
Okay.
But creatinine clearance, that's calculated from a 24-hour urine collection. That gives us a more accurate picture of GFR and overall kidney function.
So if someone's creatinine levels are a bit high, should they be worried? What does that really tell us?
Not necessarily. Creatinine levels, they can fluctuate. Age, muscle mass, even how hydrated you are. A single measurement might not tell the whole story.
Right.
Doctors look for trends over time, consider the whole picture. A sudden increase, even within the normal range, might need more investigation. But a stable, slightly high level might not be a big concern.
Context is key then, not just the numbers, but what they mean for that person's health.
Exactly. And while creatinine's useful, it's not the only marker. There's BUN too, blood urea nitrogen, another waste product. But it's not as reliable on its own.
Oh, how so?
Well, BUN levels are affected by things like hydration, protein intake, even some medications.
So we need to look at the big picture for kidney function. Creatinine clearance is key, BUN less reliable, and context matters.
This is fascinating. I'm learning so much. Hope our listeners are too.
Me too. It's great to share this.
Speaking of which, don't forget to follow us for more deep dives like this one. Now let's talk about assessing specific tubular functions, like the kidney's ability to concentrate urine or keep that acid-base balance we discussed. How do doctors measure and interpret those functions?
Well, that's where urine tests come in. A simple urinalysis can tell us a lot about kidney function, including how well they concentrate urine and maintain that acid-base balance.
So more than just if you're hydrated or not.
Oh, much more. It's like a window into the kidneys.
Mm.
One key measurement is urine osmolality. That reflects the concentration of particles in the urine.
Tells us how well the kidneys are diluting or concentrating the urine, depending on what the body needs.
So, like, if someone's dehydrated, their osmolality would be higher.
Exactly. When you're conserving water, the kidneys concentrate the urine, higher osmolality. If you're overhydrated, it'll be more dilute, lower osmolality.
Makes sense. What about the acid-base balance? How does that show up in the urine test?
Urine pH, that's the acidity or alkalinity. It gives us clues about how the kidneys are handling that balance. For instance, if they're not removing acids from the blood well, the urine pH might be too low. That could mean renal tubular acidosis.
So pH can be a red flag for some kidney problems.
It can be. Another piece of the puzzle.
Okay, so we've got osmolality, pH. The document also mentions fractional excretion. What's that? Why is it important?
Fractional excretion tells us how efficiently the kidneys are getting rid of certain substances, like potassium or sodium. Helps us understand if they're holding onto too much or excreting too much.
So, like a measure of how picky they are with electrolytes?
Exactly. A good example is the transtubular potassium gradient, TTKG. Specifically looks at potassium handling, helps pinpoint issues with reabsorption or secretion in the tubules.
Okay, so fractional excretion, TTKG. More granular details about electrolyte handling. Now let's switch gears a bit. Talk about pregnancy. What changes happen in the kidneys during pregnancy?
Pregnancy, it's a fascinating time. Puts unique demands on the kidneys. They actually increase in size, and their function changes a lot to support both mom and baby.
Wow, so they're filtering for two.
That's right. GFR, that filtration rate, and renal blood flow, they both go up significantly to handle the extra waste from mom and baby.
That's amazing. But doesn't that put a lot of stress on the kidneys?
It does. Increased blood flow, hormonal changes, it makes UTIs, urinary tract infections more common during pregnancy. Staying hydrated is key and watching for any signs of infection.
Good advice. Speaking of good advice, let's remind everyone to subscribe to our channels.
Yes, please do.
Facebook, Instagram, Spotify, and YouTube. Best way to stay up to date on future deep dives. Now, I read that blood pressure actually drops during the first trimester of pregnancy. Why is that? Seems counterintuitive.
It does seem odd, yeah. But it's a normal response to those pregnancy hormones. Blood vessels relax, resistance to blood flow decreases, so a temporary drop in blood pressure usually goes back to normal later in the pregnancy.
So just a temporary dip, not a worry. But what if someone already has kidney problems? Are there extra risks with pregnancy?
Absolutely. Pregnancy can be tough on already compromised kidneys. Women with diabetes, hypertension, any kidney disease, they need close monitoring throughout the pregnancy to manage potential complications.
Makes sense. It's a delicate balance, keeping both mom and baby healthy. Now let's talk about urine studies. What can we learn from analyzing urine, besides what we've already covered?
Well, a standard urinalysis, it's like a detective's toolkit. Gives us clues about what's happening inside. Can reveal infections, kidney stones, metabolic disorders, even some cancers.
Wow, so much more than just hydration.
Mm.
What are some of the key things you look for in a urinalysis? What do they tell you?
First, we check the physical stuff. Color, clarity, odor. Then a dipstick measures things like specific gravity, pH, presence of glucose, protein, blood, anything that shouldn't be there.
I've heard about false positives, false negatives with those tests. How reliable are they?
Like any medical test, they have limitations. Proper sample collection, interpretation are key. That's why you always consult a healthcare professional for a diagnosis.
So it's not just the results, but the context too. What if the dipstick does show something off? What happens then?
Then we often do a microscopic analysis of the urine. Look for red blood cells, white blood cells, casts, those are little structures formed in the tubules, and crystals, which can indicate certain conditions.
So a multi-step process to get the full picture.
Right.
Now, the document also mentions urine electrolytes. How do those factor in?
Measuring electrolytes in the urine, like sodium, potassium, chloride, it gives us more insight into kidney function and overall electrolyte balance. For example, high urine sodium with acute kidney injury, that could mean intrinsic kidney damage.
Another piece of the puzzle, helping figure out what's going on. Okay, let's move on to abnormal renal function. The document talks about proteinuria as a key indicator. What is proteinuria and why is it a concern?
Proteinuria just means protein in the urine, usually a sign the kidneys aren't filtering properly. A little bit can be normal, especially after exercise, but persistent proteinuria is often a sign of kidney disease.
Okay, I see. What happens when you lose protein in the urine? Why is that bad?
It can lead to complications like edema, that's swelling from fluid buildup, and hyperlipidemia, high cholesterol. The liver tries to compensate for the protein loss.
So it's not just a symptom, it causes other problems. Are there different types of proteinuria?
Yes, there are. Glomerular, tubular, overflow. Glomerular proteinuria comes from damage to the glomeruli, those filtering units. Tubular is from problems with reabsorption in the tubules. And overflow happens when there's too much protein in the blood, overwhelming the kidneys.
So the type can tell you about the cause. That's helpful. Now, what about hematuria? Blood in the urine. What causes that, and how is it diagnosed?
Hematuria can be alarming, but it's not always serious. Sometimes it's just from strenuous exercise or a UTI. But it can also be a sign of kidney stones, kidney or bladder cancer, glomerular disease.
So, got to figure out the cause. How do you do that?
First, we see if it's gross hematuria, visible blood, or microscopic, only seen under a microscope.
Okay, so how much blood there is matters.
Right. Then we'll take a detailed history, do a physical exam, order tests, urinalysis, blood tests, imaging studies, rule out infections, stones, common things. If needed, refer to a urologist or nephrologist.
A thorough investigation then. Okay, let's move on to electrolyte disorders. Always a bit tricky. Let's start with hyponatremia and hypernatremia. Can you break those down simply?
Sure. Hyponatremia and hypernatremia, they're all about water and sodium balance in the body. Hyponatremia is low sodium, hypernatremia is high sodium. These imbalances can affect a lot of things, especially brain function. Causes can be dehydration, some medications, hormonal issues.
So basically fluid balance problems affecting sodium levels in the blood. Why is it important to know the extracellular fluid volume status when you're evaluating these?
Because that helps us understand the root of the problem. Is it sodium intake or excretion? Or is it primarily water intake or loss?
So volume status tells you where to start looking.
Exactly. Then we use other findings, blood pressure, urine output, symptoms, to pinpoint the cause and treat it properly.
Systematic approach. Now, I've heard of SIADH causing hyponatremia. What is that, and how does it lead to low sodium?
SIADH is syndrome of inappropriate antidiuretic hormone secretion. The body makes too much ADH.
And ADH, that helps the kidneys conserve water, right? From our earlier discussion. So too much means water retention.
Right. And that excess water dilutes the sodium in the blood, leading to hyponatremia.
That makes sense. What can cause SIADH?
Lots of things. Certain medications, lung diseases, brain tumors, even some cancers.
So something to keep in mind when someone has hyponatremia.
Definitely. Early diagnosis and treatment are important to avoid complications.
Now, what about diabetes insipidus? How is that different from SIADH?
Diabetes insipidus, or DI, is the opposite of SIADH. Not enough ADH, or the kidneys don't respond to it well. leads to excessive urination and dehydration.
So losing too much water instead of holding on to it.
Exactly. And there are two main types. Central DI, that's a problem with ADH production in the brain, and nephrogenic DI, where the kidneys don't respond to ADH properly.
It's amazing how one hormone, ADH, can have such a big impact on fluid balance and sodium levels.
It shows how connected things are in the body and how important that hormonal balance is.
Before we go deeper into electrolyte disorders, let's take a moment to remind our listeners to stay connected.
Yes, don't go anywhere.
Make sure you're following us on Facebook, Instagram, Spotify, and YouTube for more deep dives into the world of science and medicine. All right, back to electrolytes. We talked about sodium imbalances. Now what about potassium? What are hypokalemia and hyperkalemia, and what causes them?
Well, hypokalemia, that's low potassium in the blood, and hyperkalemia is high potassium. Potassium is really important for all sorts of things. Nerves, muscles, heart rhythm, fluid balance.
So potassium problems can affect the whole body, basically. What causes these conditions, usually?
A lot of things, actually.
Yeah.
Hypokalemia, sometimes it's just not enough potassium in the diet. Happens with, poor nutrition or restrictive diets.
Right.
Increased loss is another cause, like sweating a lot, diarrhea, or certain medications, diuretics, for example. Hormonal imbalances and kidney diseases can mess with potassium, too. Hyperkalemia, on the other hand, often comes from kidneys not working well. They can't get rid of the extra potassium. Some meds can contribute, too. ACE inhibitors, potassium-sparing diuretics, and conditions like rhabdomyolysis, where muscle breaks down and releases a bunch of potassium into the blood.
Okay, so lots of potential causes there. What are some signs that someone might have a potassium problem?
Well, with hypokalemia, you often see muscle weakness, fatigue, constipation. Severe cases can even cause heart rhythm problems. That's dangerous, of course.
Yep.
Hyperkalemia, you might get muscle cramps, weakness, and again, in severe cases, heart rhythm disturbances.
So important to recognize those signs and get help quickly. How do you usually treat these potassium imbalances?
Always depends on the cause, of course. For hypokalemia, sometimes it's as simple as eating more potassium-rich foods, fixing any underlying medical problems, or changing meds. Potassium supplements are common, too.
Yeah.
And if it's really severe, you might need IV potassium.
Okay.
Hyperkalemia, we focus on lowering those levels, restricting potassium in the diet, changing meds that contribute, giving meds to help the body get rid of it. Dialysis is sometimes needed, in severe cases, to quickly remove the excess potassium.
That makes sense. Now let's talk about acid-base balance. The document mentions the kidneys are key for keeping that in check.
Yeah.
How do they do that?
Kidneys are like the body's pH regulators, constantly working to keep the blood at a stable pH. They do this by reabsorbing bicarbonate, that's a buffer to neutralize acids, and by getting rid of hydrogen ions, the acidic part.
So they filter and regulate at the same time. Pretty impressive. What happens when that balance gets messed up? What are the consequences?
Well, you can get metabolic acidosis or metabolic alkalosis.
Sure.
Acidosis means too much acid in the blood. Can happen with kidney failure, diabetic ketoacidosis, severe diarrhea. Symptoms might be fatigue, shortness of breath, confusion.
And alkalosis.
Alkalosis is the opposite, too much base in the blood. Prolonged vomiting, overuse of diuretics, some hormonal problems can cause it. Muscle weakness, tremors, even seizures in some cases.
That's pretty serious. How do you diagnose and treat those acid-base imbalances?
We look at blood gas values. pH, bicarbonate, PCO2, that tells us about carbon dioxide levels. These values help us figure out what kind of imbalance it is, how bad it is. Treatment always depends on the cause, of course.
Right.
If it's diabetic ketoacidosis, you got to manage the diabetes, fix the electrolytes. Alkalosis from diuretics, maybe adjust the dose or change the type of diuretic.
So fix the root of the problem. Now let's talk about renal failure. What's the difference between acute and chronic renal failure?
Acute renal failure, ARF, that's a sudden drop in kidney function. Happens quickly, over hours or days, usually from things like severe dehydration, infections, certain medications, blocked urine flow.
Okay.
Chronic renal failure, CRF, that develops slowly over time, months, years even, usually from long-term conditions like diabetes, high blood pressure, polycystic kidney disease.
So different onset, different causes. What about diagnosis and treatment? Similar or different?
Diagnosis is pretty similar for both. We take a good history, do a physical exam, blood and urine tests, imaging. Treatment's different, though. For ARF, we got to fix the cause, support kidney function while they recover. FARV fluids, meds for blood pressure and electrolytes, maybe a dialysis for a while.
Okay.
For CRF, the goals are to slow it down, manage complications, and eventually get ready for dialysis or a transplant.
So early detection is key for both, but the long-term approach is very different. What are the options for people with end-stage renal disease when the kidneys just can't function anymore?
That's when you need dialysis or a transplant to survive.
Let's talk about dialysis first. How does that work exactly?
Dialysis basically does the kidney's job for them, filters the blood.
Makes sense.
There's two main types, hemodialysis and peritoneal dialysis. Hemodialysis uses a machine outside the body, usually 3 times a week at a center.
Okay.
Peritoneal dialysis uses the lining of your abdomen, the peritoneum, as a filter. You put a special solution in your belly, it stays there for a while, waste products and extra fluid go into the solution, then you drain it.
Wow. So both filter the blood, but in very different ways. What are the pros and cons of each?
Hemodialysis, it's more efficient, faster. But you got to go to the center, and it takes time. Peritoneal is more flexible, you can do it at home, and it's gentler on the body. But you got to do it every day, and there's more risk of infection. It really depends on the person, their lifestyle, and what their doctor recommends.
A personalized decision then. Now, what about kidney transplantation? How does that work, and what are the benefits over dialysis?
Transplant, we take a healthy kidney from a donor, put it into the person whose kidneys have failed.
Big surgery.
It is, but it can let you live a more normal life, no more dialysis. And with better immunosuppressant meds, the success rates are much better now.
That's good to hear. How do they choose donors? And what kinds of donation are there?
2 main types, living donor and deceased donor. Living donor, that's usually a family member or close friend. Shorter wait time, better chance of success because the kidney is healthier and a better match.
Yeah.
Deceased donor, that's from someone who has recently died. Longer wait, but still a life-saving option.
Okay. Now, what about glomerular diseases? What are those, and how do they affect the kidneys?
Glomerular diseases, they affect those tiny filtering units in the kidneys, the glomeruli. Remember we talked about those?
Yeah, at the beginning.
They mess up the filtration process, can
Yeah.
cause proteinuria, hematuria, hypertension.
So they directly affect the kidney's ability to filter. What are some common types of glomerular diseases?
There's IgA nephropathy, membranous nephropathy, focal segmental glomerulosclerosis, minimal change disease. Lots of names, I know.
It's a lot to keep track of.
Each type has its own quirks, but they all damage the glomeruli, and that hurts kidney function.
How do you diagnose and treat these?
Good history, physical exam, blood and urine tests, often a kidney biopsy too. That lets us see the glomeruli under a microscope, see the specific damage.
Yeah.
Treatment depends on the type and severity. Some respond well to meds that suppress the immune system or reduce inflammation. Others just need supportive care, manage the symptoms, slow the progression. Sometimes dialysis or transplants are needed.
So early diagnosis is important, and the treatment needs to be tailored to the specific disease. Now, what about tubulointerstitial nephritis? How is that different from glomerular disease?
Tubulointerstitial nephritis, or TIN, that's inflammation affecting the tissue around the tubules, not the glomeruli themselves.
Okay, different part of the kidney.
Right. Can be caused by meds, infections, autoimmune disorders. It messes with the tubule's ability to reabsorb things, concentrate urine, leads to electrolyte problems, acid-base problems, even kidney failure.
So still serious, even though it's a different area. How do you diagnose and treat TIN?
Again, thorough evaluation. History, exam, blood and urine tests, sometimes biopsy. Treat the cause. If it's a med, stop it or switch. Infection, give antibiotics. Autoimmune might need immunosuppressants.
This has been a really incredible deep dive. Learned so much about the kidneys, from the tiny parts to big diseases and everything in between. It's amazing how important these organs are, even though we don't often think about them.
It's been a pleasure sharing this information. Hopefully people have a new appreciation for their kidneys after this.
Absolutely. Huge thanks to London Heartbeat C Academy for the amazing source material. Their dedication to medical education is so valuable.
Couldn't have done it without them.
And to our listeners, thank you for joining us. Don't forget to subscribe to our channels, Facebook, Instagram, Spotify, and YouTube for more deep dives like this one. Knowledge is power, right? Understanding our bodies helps us take better care of ourselves. So, until next time, stay curious, stay informed, and take good care of those amazing kidneys.